the transition from old school paper charts to electronic, and then to, okay, now this is overwhelming. Let's start having some pre-filled sections. Let's start having some templates. And then, I think we've just kind of gone a little too far now where, okay, do we really need all of the auto-populated information? What do we actually want and need in there? And what's going to actually be important for us to review before we allow that auto-population to move forward?
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
On this week's episode of First Case, we are speaking with Claudia Cometa, Executive Healthcare Consultant and owner at Peace Advocacy Group. And Chris, we are changing the script today, and we are talking about advocacy for the patients and how that looks as they move through the healthcare system. And it's really going to be a good reminder for all of us, no matter what department we find ourselves in the hospital, to really have our perspective brought back to a patient-centered one.
This might be our 9 to 5, but for that patient, this one day could change the rest of their lives. And we need to be reminded of that. And I think Claudia is going to be an excellent guest to have in that realm.
Yep. So hang on to your hats, and we will be right back with Claudia Cometa.
Hi, I'm Chris Blevins.
And I'm Melanie Perry.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Claudia Cometa, Executive Healthcare Consultant and owner at Peace Advocacy Group. Claudia, thank you so much for being on the show today.
Definitely my honor and pleasure. So happy to be here.
Oh, I'm so excited to have this conversation today because what we're doing today is really shifting the conversation from the different topics that we've had so far this season. And we're actually going to drill down into patient advocacy. And I know that as nurses and as scrubs, our mission is advocating for the patient while they're in our ORs. But who advocates for the patients as they move through the healthcare system or when they have to make hard decisions? Who helps them understand their choices? And those are the things that we're going to look at today and really dive into your passion and your role, Claudia. But before we do all of that, will you just introduce yourself and tell everyone a little bit about you?
Yeah, I'll try to condense my story a bit. But yeah, so I'm Claudia Cometa. I'm a pharmacist by training and I guess profession and education. So I graduated from the University of Florida College of Pharmacy in 2003. So we're 20 years out from that, which is insane. And
right.
I worked in all varieties of areas of pharmacy. I completed an extra year of clinical training, mostly because I had the foresight to know that working in a retail setting was not going to be pleasant. And as many of you know, when you walk into I won't name a specific place, but when you walk into a pharmacy, you're not going to see a lot of smiling back at you. So it's not a pleasant environment. So I worked in a lot of one-on-one and one-to-many environments where I was either with patients inside of a clinic or I was with a group of physicians inside of their internal medicine clinic. Being a drug educator, I managed high-risk medications for many years. When we used to use warfarin as the primary blood thinner, I was the one managing that. So I worked in a couple different environments, mostly in the clinical space. And so had a good assessment of how the system worked and how teams worked and how communication worked within the teams. And so I did that for many years. We moved, so it looked a little bit different here and there. And then my dad got sick in 2016 and was diagnosed with lymphoma, which was sort of out of left field. It was not anywhere on my radar. And when that call came in, I was a little blown away. And then I just immediately dove in, as any of us would who have the healthcare education and expertise and training. And we're the ones who have to step up when, a family member or friend or whomever asks us to help. So I was the obvious one because nobody else in my family is medically trained. So I jumped in, and what I saw from the other side of that equation was shocking to me. It was disappointing. It was all of the things. And I couldn't believe that the system that I had worked in looked like that from the patient experience standpoint. And that in and of itself is sad that I didn't have any awareness of that. And so,
I think that's all of us. We're in the system. We're part of the system. And so we don't see it from an outsider's point of view. We don't see it necessarily as a patient until we have those unique experiences. So let's dive into that a little bit. Like, what did you experience as you helped your dad move through this? What was it like?
Yeah. Well, the first phone call came from my mom when she drove him to a hospital location I wouldn't have chosen for him, but she didn't think to ask me before she drove him there. So that was the first challenge is, we have his spleen actually burst and had ruptured. So he needed emergent surgery. Whoa. And he was not in, a lot of people have, and you all know this, but not everybody knows this. A lot of people feel like every hospital location has the same types of physicians and resources and staff. And that's not the case, as we all know. And my mom didn't know that either. And so the first challenge was, now we need to get him to the location that can actually perform the surgery as quickly as possible. And so, we did all that and navigated that. But then it was just, error after error along the way. It was dismissive physicians along the way. It was, with just some tangible examples, his weight was documented as 300 pounds and he was like 170 on a good day. And so that all, of course, plays into any weight-based drug dosing, which all includes of that. Chemo, which he eventually did. And so, and those things popped up as I was just monitoring his portal, and things that he wouldn't have even glanced at or known that occurred. And, then physicians, he went to a pulmonologist. The fellow is the one that saw him, and the fellow, as often this is the case, the default medical record just kind of populated with whatever it populates, whatever the IT company, decides to populate it with. And so, it's all of the assessment stuff. And so it said, lungs clear to auscultation, as you all know and have seen many times. And he never listened to it. He's in the pulmonologist's office. He never listened to his lungs. I didn't find this out until after. This is an appointment I was not at. So the attending assumed that they had listened to his lungs because that's what the note said. And I mean, it's just,
and he's at a pulmonologist,
and that's literally their job.
Specialty
this is all they have to work. Nobody,
right?
They're not looking at the kidneys. Like this is it,
right?
And 2 days later, he had a chest tube because nobody heard what was actually going on. And so, I approached the attending after that, and I was like, "Look, my husband's a physician, so I'm very aware of how this goes. I know training has to happen and mistakes happen, but as the attending, it is your responsibility to step up and make sure that what is being documented is actually what's happening."
How did he respond to that?
He was mostly quiet because there wasn't a lot to say. And, and of course we moved on.
Can't eat crow really well. I don't think that our physician population is very good at that part, right? And that's recognizing that they made an error and that they're human. But I think also on the other end of that, like we as their patient population, we have abnormal expectations, right? Like we think that they are supposed to be, closer to God, right? Or just the ability to almost practice perfectly. We forget that there's that human aspect to it. So you have errors at both ends in that instance.
Absolutely.
And how does a patient know that they even can make a choice?
The most patients wouldn't even know that lack of attentiveness to the physical exam was what ended up causing the sequela. Like they wouldn't even know to put the pieces together or to backtrack and say, what went wrong here? Let me identify it so that I can bring it up. I mean, most people, and how could they be expected to know that? It's not even reasonable to put the onus on people like that. So it just, things like that continue to happen. I ended up moving him out of we fired 2 different hospital systems. I moved him 2 hours north to where I was living. We ended up at that hospital system. And then, of course, by that point, his cancer had spread and he ended up passing away a year later. But I took all of that learning, I look at, I mean, he was in the ICU multiple times. He became critical multiple times. And, as I look around the ICU bay and I'm looking at all of these other people just laying there, I'm just thinking, how in the world, I'm literally like monitoring real time. Labs are coming in. I'm communicating with the primary. Okay. I'm real time navigating this. And I just can't even imagine having, the scenario that's surrounding him, which is somebody's just laying there and hoping all of the pieces are being put together and all of the T's are crossed and the I's are dotted. Like, that's not actually happening. So who's watching out for these people? So pharmacy was very much an analytical decision for me. So to go into pharmacy, it was very checkbox. Okay, I'm good at chemistry. It was suggested to me as a field because I was good at chemistry. I actually wanted to go into healthcare for a multitude of reasons, because I wanted to help people and because back then, that was the secure field, right? Like, healthcare is the secure field. That is not language that's used today, but that's what the language was used back then. So it checked all the boxes. I wanted to eventually have a family, and it was going to allow me the flexibility to potentially work, 1 or 2 days. I mean, it just checked all of the boxes. When I decided to do advocacy work and executive healthcare consulting work, it was not analytical at all. It wasn't actually in my head at all. It was fully in my heart. And I had never experienced that kind of a decision making in my career before. It was just a deep inner knowing and I don't even care like who thinks what, or there was just no need to collect opinions on it. It was like, we're just moving forward. So yeah.
Yes.
Well, so we have a question because there's, now that the patient health record has become, electronic, and we do talk about processes in healthcare, right? The more efficient that you are, the more efficient the care is supposed to be, and the more effective it's supposed to be. But I wonder if the ability to just check a box, like when we're talking about an H&P or we're talking about vital signs, I think almost the default boxes are so easy to check that sometimes I think we health providers make mistakes and errors because it is just a click of a mouse, as opposed to, having to write out everything and have that kind of mind body check. I don't know, Melanie, you're a nurse too. Do you find that to be the case?
I was actually just thinking that because I know in our own electronic records in surgery, a lot of things to make it more efficient, because charting is so just much of what we have to do to make it faster, to make it better. We have presets. We have things that are pre-filled out. And I can't tell you how many times I'm doing a case, and because all of this preset information is connected to that prep card, it already says, that we did all this stuff. And a lot of times even maybe laterality might have been selected, but we're actually doing the other side or whatever. And so you have to actually read what pops up into those boxes to make sure that it actually applies to your patient. But to your point, Claudia, how many times do we just roll with what already fills in the blank and we don't actually pay attention or do what the checked box says that we did?
Yeah. Or make the assumption that someone did in our stead. Right?
Yeah. Yeah. I think, the transition from old school paper charts to electronic, and then to, okay, now this is overwhelming. Let's start having some pre-filled sections. Let's start having some templates. And then, I think we've just kind of gone a little too far now where, okay, do we really need all of the auto-populated information? What do we actually want and need in there? And what's going to actually be important for us to review before we allow that auto population to move forward? And it's a real problem. I mean, it goes so much deeper than even this one anecdote of my dad. And so most physicians will say they feel very overburdened by technology, which was supposed to relieve the burden. I mean, most of them will say that that's their primary cause of stress and just overburden, time commitment to all of these buttons and clicks. And are we compliant? And, most people would just rather go back to paper. So in my own practice, myself and the advocates that work with me, we use a system, and I've taught them, and I have done this myself. We only use free text. All of the notes that we type are like, we have literally typed them. There's nothing populating. If it's there, it's because we intentionally typed it. And it's just so freeing. Like, it's like we can why isn't that just normal? I get that there's some stuff, but really when you go back and read the notes, I read progress notes for my clients all the time, and it's just endless amounts of inundation of data that is not important for that note. And it's insanity. Yeah.
So let's talk about then shifting back to that emotional change that you had. You had this analytical decision to be a pharmacist, but then you were emotionally and passionately driven to make a career change to fix a problem that you saw. How did you go about becoming the advocate that you are today?
Yeah, it's a really impactful question because it really is a becoming. And in becoming, I had to unlearn a lot of habits, conditions, belief systems that, came from a lot of years of academia and what healthcare training and education teaches you. And, which is you don't do anything until you absolutely feel like you know everything about it. You don't do anything until you have a degree to support it, a credential to support it. You just don't do this, right? So, I felt myself, I watched myself feeling like, okay, well, I want to do this, but maybe I should get an MBA because I need to have some evidence that I'm allowed. I have some permission from, I don't know who. There's some gods above me.
The magical piece of paper that gives you a degree and gives you permission.
The big day.
Right. And then I just thought, why do I think this? So I really had to start unraveling things as I moved in this very untraditional path that really had not been paved much at all. And so it really has been a becoming and an unbecoming of who I was as a consequence, a result of the training that we all, regardless of what our specific degree is in, there's an element of healthcare professional training that is, a foundational piece. And it tells you when you're worthy and when you're not, and when you can move forward and when you can't, and how you should know and never not know. And, there's just this undercurrent. And so, I had to unlearn a lot of that. But honestly, that process has been the most impactful for my entire life within the profession that I'm currently in, and also just personal. I really teach my clients now on a whole how to think about their healthcare in a similar approach as I did with regard to unlearning and then relearning what's going to work for me. So it really, like, the mindset piece has been the absolute largest. The logistics, I train and teach up and coming advocates also. And I tell them we'll get to the logistics. Like, I know everybody wants to start a course and, let's get to what do we need to know, like get what ABC, what's the recipe, we're very linear thinkers, like very linear thinkers. And I was like that too, that this has taken some time, but it's like, tell me what I need to know for the test. I'm going to know it for the test. Tell me, it's very just whatever. And I tell them, this is a mindset shift more than anything, because you can learn how to be an advocate. You are already advocating on so many levels. This is not let me learn a new trade. This is let me learn a different way to think first.
So I really want to know your opinion on this, because not every single patient doesn't have someone in their family or someone close to them that maybe has medical training and can advocate or help them make these decisions. And these patients are at one of the scariest parts of their lives. As you said, like, your father's lymphoma came out of the blue, and his spleen rupturing. All of those things are trauma situations where we already know that we don't think clearly in a trauma situation to begin with. How do we advocate and explain to someone, in those situations, that they have choices when their brain is already, in such a fight or flight stance? I know that we have people in our hospital systems, and that's their job, is to, go over all of the HIPAA and all of the patient rights and responsibilities. But these people are, they're not thinking clearly to begin with. How do you stop and tell them in this scary part that, that there is an option or that they have a say? Where do we go from there?
It's typically relaying that information to a friend or family member. They don't have to obviously be trained in any kind of medical education, but just letting the person who could make decisions clear-mindedly at that point in that patient's care, look for assistance. So there are patient advocates that are employed in facilities. So you'll see that title relatively frequently now. But the difference is they are ultimately still an employee of that facility. So there is a level of conflict of interest, a very deep level of conflict of interest.
Sure.
They're not looking to say, they're not looking to go up to the physicians inside of their same institution and say, hey, this is wrong. Hey, you screwed up. Hey, that's not the case. They're usually like the complaint department, or they're the financial department, or they're, depending on the institution, they have different roles. Sometimes like if they're in the transplant area, they might be the one that kind of gets people to their next, there's so many pieces. And so they kind of tie in all those pieces, but ultimately there's a conflict of interest. And so the difference with independent advocates and people like me is that we have there's no conflict at all. The only interest is the person who hires us. And so I don't care what doctor or what hospital, or I have no allegiance to any of them. My allegiance and my interest is only that of my client. So in that scenario, let's say you were to, or somebody listening were to identify a potential need for somebody like me, it's usually the daughter, the wife, the friend who is finding us, because the patient, as you just laid out, is usually in the bed and isn't able to think clearly, isn't able to now micromanage and project manage. Like they're not on their laptop. Like, I wonder who could help me. I mean, that's not realistic. So it's usually somebody else finding us. Yeah.
So how do potential clients even know that services like yours are out there?
Yeah, that's a good question.
How do people find you?
So there are some nationwide directories, and if you were to, and most of them have, like SEO priority. So if you're Googling patient advocate or healthcare advocate, and not everybody knows that language either. And that's a huge part of the education piece, which I'm so thankful that you all are helping with that, because the more we can talk about it, the more people realize that we exist. So not everybody knows to search for it. Not everybody knows even the language to search for, but eventually, if they search long enough, they'll find patient advocate or health advocate. And and one of the directories will pop up. So there's actually multiple of them, and they can search by their zip code. Although I help people across the country, so it really doesn't matter. But if they're in a critical situation where they really want somebody with feet on the ground, I absolutely understand that. And you can, all of them search by zip code. And so you can find who's in my area. You can find, everybody comes into this with a different background. So we have RNs, we have PharmDs, we have MDs, we have patients who don't actually, which I think is fantastic, who don't have any necessary healthcare degrees or credentials, but they've been through enough that they want to help in any way they can. And so maybe their price point's less, and maybe their scope of what they can do is less, but they want to step forward and do something. So you can go through and see everybody's credentials, what they've done, you can go to see their reviews, and then, pick a couple. Usually what I found is people will, pick a couple and schedule calls with them. And because this is a pretty big decision, you're going to be really working with this person pretty deep and potentially for a lengthy amount of time, depending on how bad the crisis is or what we're looking at. So.
Well, and you said personal, right? Like I would imagine you get attached to some of your clients and really, I think that would be a hard line for me, right? Like you really get attached into making sure that they're having good care, but also that their outcome is a positive one. Yeah, that would pull at my heartstrings.
Yeah,
most definitely.
I think it's really a beautiful thing, honestly, and I've really embraced that because I didn't have that in my clinical work. And people came in when I was in the Coumadin clinic. People came in monthly, and I saw them for brief periods of time. But the appointment slots were like 15 minutes. So I'm at the point now with my clients where they could call anytime. A doctor on their behalf could call anytime. And I don't even really have to look up, unless it's a brand new client and I've only looked up their chart once. I don't have to, I know what meds they're on. Like if somebody is going to ask me on the whole, I know what meds they're on. I know what's going on. I can tell you the history. I don't really have to reference my online system at all, unless there's some detail that I forgot about. But we know our clients very well. I mean, we are part of their family. Yeah.
So I'm curious, as you're working with your clients, you are their advocating for them, maneuvering through the healthcare system. But we always have those HIPAA laws and HIPAA rules, and how do you navigate that so that you can speak on behalf of the patient, so you can access their charts, so that doctors can talk to you, or even where doctors will listen to you as somebody who is not the patient or their family member? How does that work?
Yeah. So it really starts with the first phone call. If it is, which it usually is, a family member calling on behalf of a loved one who's currently in the hospital or sick somewhere, then the first point of contact is, are you power of attorney? And if you are, I need verification of that. So I'm typically getting a copy of the power of attorney so I can confirm that before we even move forward and talk in any depth about this patient's case, because I know in a lot of cases, I can't get them on the phone right now to tell me that you are even allowed to talk to me about this right now. So, and that they want you to. So I'm getting the power of attorney paperwork out of the gate. And then once we're set up and onboarded, like I know we can legally move forward, then the next step is, if we don't have access to the online portal system, because most of my clients are virtual. There are a few who have been local over the years, but since COVID, I would say the vast majority are virtual. And so we're getting access to patient portals. And the way that works is, for most of the patient portals, they can actually add me to their portal. You know, they can authorize that online and add me. So now, like if it's my chart, I have my own my chart, and the clients of mine who authorize me to see their my chart, it's like a drop down for me. Like I have me and then I have my clients. And so I can see all of them, right? If that isn't a potential with the specific portal, then they can decide either to, many of them literally just give me their access. That's their authority to do that, or they will ask if the system has like a friends and family, like separate password, guest password, whatever, or if they're just completely uncomfortable with that, which I tell them, here are all of the options and you do whatever you feel most comfortable with. If all of those options don't feel right to them, then in my system, in my electronic medical record system, they can upload documents, you know, more in the more old school way. So they can, you know, save it to their computer and just upload the documents they want me to see, or I've asked them to get if they feel comfortable sharing with me. And so that's how we do medical record sharing. So I can review. And then with regard to the patient, you know, portal systems or the systems within their hospital systems and their doctors, they just add me to whatever is called friends and family list, authorized user list. They just add me. And really after one or two visits, most of the physician's offices end up knowing me, and nobody really has to reference that anymore. But if they do, if there's like a new staff member or something and they need to reference it, then they always can go through the chart and they list me. So I walk them through how to do all of that so that we can get all of that in place. So when I do call on their behalf, we're not doing this over and over and over again.
And they will speak to you when you call on the patient's behalf. You can actually speak to the physician.
I really never have an issue.
Wow.
Yeah.
That's
really
surprising.
Cool.
Really
I know
is.
that actually really surprised me.
Yeah.
What happens when you have to tell a patient or one of your clients news that they don't agree with? You know, I would imagine there are moments where what you think they should do is different from what either their power of attorney thinks they should do or they themselves. How do you navigate those waters?
Yeah.
It can be uncomfortable.
So in the beginning, part of the onboarding process is actually laying out goals. So, and this comes as a novel approach to a lot of people, because most people in their care are not asking them, like, what are your goals? And so they're not used to identifying their own goals either. And they're not used to being given the permission to do it. So we go over that, like, what are your top 3 goals right now? Depending, you know, based on your current situation, what are the top 3 things that we want to work together to achieve? And so those may not be what I would have chosen for them. And there may be, you know, 10 different things we need to work on, but the priority for me is what's the priority for them. So we go through what's the top 3. And, you know, of course, if we're in crisis mode where, you know, that's happened a couple of times where the patient is actually intubated in the ICU and the family member who's the power of attorney has me involved, you know, at that point we're navigating crisis. So we're not sitting down. The goal is to let's get out of the ICU, right? But assuming we're past that, we're not in crisis mode, we're going over goals. And my only interest is moving forward with those goals. And so there have been times when another family member may not necessarily be aligned, or they don't want what the patient wants. And so we encourage a lot of, it's amazing how many families don't talk. Like they'll talk to each party's talking to us, but we're like, have you actually talked to your mom, or have you actually talked? And they don't, and they'll leave the room. And it's like, so we encourage a much, you know, more open line of communication so that everybody understands what the person actually wants. You know, what does the person actually want? Are we to the point now where we have exhausted all of what the Western medical system can do for this person? And if that's the case, let's be honest with that and make decisions from a place of what the patient wants and what we are able to implement. And so we have a lot of those difficult conversations. And yeah,
it reminds me of transitioning, into palliative care. It's hard to get own family members to talk to us sometimes about end of life decisions or how they would want, care to happen. And so I can imagine trying to get them to speak about it, especially with an outside source. Well, maybe being an outside source makes those conversations a little easier. But yeah, I would think you have to be ready to have tough decision-making skills. And I think that you can navigate the families through those in a way that maybe their spouse or father or daughter couldn't do. So I really commend you for that. Melanie, any final thoughts or anything from?
I think it helps to have somebody else sometimes who is one step removed from the situation, to be able to have the clarity, to be able to have the knowledge and the ability to bring that support to a family when they are suffering, when they are going through something like we've talked about already, when you're in fight or flight mode, when you're overwhelmed, when there's so many questions coming at you, to have that third party who's there on your behalf to advocate for you and to give you that sense of stability when you are all over the place is gold for families as they move through the healthcare system. And I think this helps our audience to be able to think about that patient on the table as they are moving through the situation they're in, whether the surgery is an elective, whether it is a life-saving thing, an emergency splenectomy, or anything else. They've got a lot on their plate. They've got a lot on their mind, and we can be more caring caregivers as we bring them in for their surgeries. And Claudia, I really want to give you the opportunity, though, before we bring this conversation to a close. You talked about not letting, having a degree or a piece of paper or anything else keep you from doing what you felt called to do. If somebody else saw a need and they wanted to try to meet that need, what advice would you give them as they moved out of maybe a traditional space into something they really felt called to do, to advocate for?
Yeah. An audiologist, a young female audiologist, just reached out to me from the UK, and she's like, I've seen some of your LinkedIn posts and I want to do this, but I don't know anybody doing this here. And I don't know if I have to have a credential. And so what I told her is, it's going to feel like a lonely path at first if you're trying to pave a path that, nobody has, or you don't know who else, might have paved a path. So I really told her to find there are always others. There are always others who are thinking the same thing, who see the gaps in the healthcare system, who know that there's more that they can do, but they don't know who to talk to about it. They don't know what it's going to look like. They don't know how to curate it and ideate about it and create a business. I mean, it just all seems so overwhelming. So my advice to her initially was to seek out people either who have done it, get a mentor, get advice, get other people who are around you who are talking about this too, and start just scheduling meetings like, hey, let's meet on Wednesdays and let's just start brainstorming. And as you just take the next baby-ist of steps, like the path will be shown, but you can't keep it all in your head and in your heart to never come out to fruition, to execution, because you'll just be frustrated and if there's a desire. What I found is if there's a burning desire for somebody to do something, it's there for a reason. It's because somebody else needs you to do it. And so sitting on it and getting frustrated that you can't do it because your boss doesn't give you the time, or none of that is helpful. We either create or we complain, and you can't do both. So,
absolutely.
I say just get into creation mode, whatever that looks like. Create by brainstorming, create by journaling out what this might look like. Just start creating, which we aren't, I don't think most healthcare professionals identify at least I didn't identify ourselves as like artists or creators, or, we don't we're not that usually that type. And so creation sounds weird, but part of this is the becoming, and part of the becoming is shifting your languaging and verbiage and your allowance of your gifts. So yeah.
I love that. That is fantastic advice. Find your people and step out and do it. Don't let fear hold you back. And if you're called to do something, then you will have the ability to do it if you just step out and do it. I love that. Claudia, thank you so much for joining us today. This has been a fantastic conversation.
Thank you so much for having me.
That was Claudia Cometa, Executive Healthcare Consultant and owner at Peace Advocacy Group. And Chris, I think we just had a lot of good reminders about seeing our patient as a person, as someone who is going through something that's scary, that is going through a unique situation to them. And while we may do 4 total knees and OR5 every single Tuesday, or we might do 3 gallbladders and 2 appendectomies and whatnot. For us, it might just be every day, same as usual. But for each and every one of those patients, it's a new experience. It's something unique to them, and they're going through a lot. And being able to navigate the healthcare system and understand it really helps to have somebody who helps you get through it and know what in the world you're dealing with.
It really does. And I think specific to the operating room, time is money, right? Efficiency, efficiency, efficiency. We hear that word all the time. But I think that in doing that, sometimes we can lose focus of the humanity in all of it, not just our own humanity, but also that of our patients. And what I found so interesting is that Claudia kept using the word freeing. Did you hear her? So many of these pathways are freeing. Having the ability to free text her notes was freeing. Becoming an advocate was freeing. And it makes you want to grab some of that freedom, right? And go down those pathways and not be so scared to speak up when we don't click the box or that box doesn't apply to that patient. And so grateful for that conversation.
No, absolutely. I definitely, as I head into the OR here in a couple of days for another shift, I think it will definitely affect my perspective again on my patients, but it's always a good reminder, very grounding. And I think we can all benefit from that reminder. So on behalf of Chris, myself, and the whole team here at First Case, thanks for listening to this week's episode.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.